Guys, this is my go-to, who I refer to my patients when the flow protocol can't get them there, when there's something that's clearly there.
They were able to actually reverse certain autoimmune conditions like MS. A lot of our autoimmune patients were starting to get pregnant a lot easier. Their bodies were returning to a healthier weight, their energy was increasing.
Dr. Dan Kellams is a doctor of Chinese medicine with a specialty in integrative and functional medicine. National speaker,
licensed acupuncturist,
founder of Peak Vitality Medical Clinic in Denver, Colorado,
functional medicine director for the Tucson Wellness and Vail Wellness Medical Clinics in Tucson, Arizona.
Then we also have this other unknown category where this is the person that we know something's wrong. It's all over their face. They feel like crap, they look like crap, they don't even look alive, yet they go to their doctor and the doctor says, everything's fine. It's all in your head. And so that's your only solution, because your Western medicine is out of options.
The healthiest version of you is the most efficient version of you. It makes adaptations, it requisitions resources and moves them around. But when your body makes an adaptation, it loses them. There's an argument made that it's the most important is the minerals. You lose your minerals and your electrolytes, like nothing works right.
Let's talk about the plateau.
A few years ago, a good friend of mine, he was in the 300s. So he just decided he was going to start jogging. And when he started jogging, he just started shredding down, like unbelievable. And it inspired people around him. I want to lose 10 pounds, I'm going to jog. He got to a certain point and he was no longer losing the weight. And so I think the plateau is an accumulation of four major issues. The first is
Dr. Jones, world-renowned weight loss and functional health expert,
chiropractic physician,
noted author, guest speaker,
functional health expert.
Welcome back, everybody, to the Lasting Weight Loss Lounge with your host, Dr. Jones. And I'm super excited for today's episode. I'm actually here with a good friend of mine, Dr. Dan Kellams. Me and Dan, man, how far? Like, what, 8 years ago?
Yeah, back to 2016.
Wow. Yeah, time flies. That's for sure. I'm going to let you do your own intro, but yeah, I'm excited to have you on because, you know, I've always called you the functional wizard because out of all the functional docs I know, man, you're the brain and you're the guy that I'm sure everyone else kind of sees what I see, which is the technical stuff when it comes to functional medicine. So, you know, without dragging that on too much, please do an introduction of yourself, like your background, maybe quickly kind of talk about what functional medicine is, and then we'll kind of go from there.
Yeah, absolutely. And first of all, I'm very grateful to be here. That was a great introduction to me already. I appreciate that. So, you know, I originally went to school for Chinese medicine. My master's degree is in Chinese medicine at the American College of Acupuncture and Oriental Medicine in Houston. And what was really unique about that experience is my internship was partially at the Houston Medical Center at Hospital. So there was some clinical trials that were going on while I was in the clinic there that I got to be a part of. And that really got me interested in the science behind, you know, what it was we were doing. And so I returned to the school and completed my doctorate in Chinese medicine with a specialty in integrative medicine. And it was really cool because it really got my hands in a lot of different research studies and outcomes. So I got really heavily involved in that. And, you know, over the years, and you and I had, you know, we had a really good past and experience in helping people's bodies be able to heal and recover. And on the functional medicine side, I got really heavily involved with that on a process, really this downstream process due to autoimmunity in my family. Yeah, and it's been super fascinating. It's, you know, autoimmunity is a deep pit, right? There's so many different things there, a lot of different causes of autoimmunity. But, you know, when you're working on that, you have to look at the entirety of the body. And what I found when I was really taking the approach with Chinese medicine, I started implementing all these dietary changes and supplement changes. And the Chinese medicine has its own diagnosis and its own diagnostics, which is super fascinating. But what I found was when I would look at the research studies on what was going on with somebody and what herbs or supplements or different type of lifestyle dietary interventions, and I coupled that with the Chinese medicine diagnostics, it really helped me leapfrog forward with people. I was getting results a lot faster. And that kind of was this introduction into, okay, what about labs? And when I was first starting doing this, it was just considered, physiology. It wasn't really considered functional medicine. I don't think that term was popularly used then, but that's how I got into the process. And over the time, the focus still was on autoimmunity. And with autoimmunity, you had to have a really good grasp on gut. And with those two came hormones. And then what we found was a lot of our autoimmune patients were starting to get pregnant a lot easier. And, their bodies were returning to a healthier weight. Their energy was increasing, but they were getting pregnant. So they started referring other people to us for fertility and hormone issues. And we found, there was this huge gap in our conventional care when it came to hormones and fertility, not looking at the gut and these inflammatory processes and nutritional deficiencies. And so, I joke around because a few months ago I was at the airport and somebody came up and they said, "Hey, you're the fertility doctor." And I was like, all right, that was funny. I was like, well, yeah, it's definitely become an obsession, but that's how I landed here today with you. And the process, like when you're looking at what is functional medicine, a lot of people have a lot of definitions, and really what I say is you're looking at these really, really base functions in the body at a molecular level almost to understand what does it take to get to optimal. And so that's what you're looking at. And then from the other perspective of when things have become disrupted, what has happened to create that shift? So, there's a lot of different theories of disease, and I think this really applies regardless of what kind of condition someone's dealing with. So you have these things that make up a person who they are, their diet, their lifestyle, their exposures, and their genetics. And then you have what we consider the triggers. We say, okay, so there's you and everything that's going on. So the unique combination of these exposures in your diet and lifestyle are going to be things like your micronutrients and macronutrients. Are they too high, too low? Do you have sensitivities or intolerance to those? Is there any microbial presence that shouldn't be there, or the gut bacteria that should be there? Is there anything lacking? What do your stress hormones look like and the stress mechanisms in your body, the nervous system? What do the overall hormones look like and these 6 major pathways of hormones? And then also toxins. And when we think toxins, we're not just medications or environmental toxins. We're also thinking about what is the metabolic waste left over in our body. So you have these triggers, and what we've found, and this is, our approach when it comes to functional medicine, is the healthiest version of you is the most efficient version of you. So the healthiest version of you is this most efficient version. And the moment your body has any disruptions in all those areas, it has to make an adaptation. When you're looking at a person, there's all these different theories of disease, the inflammatory theory of disease, the molecular theory of disease. There's the information theory of disease. It's what Dr. David Sinclair termed it in his research in his book, Lifespan. But when you're looking at kind of a unified theory, basically a person is a combination of diet, lifestyle, nutrition, and genetics, right? And then what happens is you have all these exposures, and your body, the healthiest version of your body, is the most efficient. And the moment something gets disrupted in your body, it has to make an adaptation, because your body's not going to give up. It's like, what does your body do in low vitamin D? Well, it makes adaptations. It requisitions resources and moves them around. But when your body makes an adaptation, it loses efficiency. And it's almost like, your engine can run with low oil, but it's going to create heat, and that heat creates friction. And the same thing occurs in the body. The more efficiency that's lost, the more friction that occurs. And the more that accumulates, the body then leads into this oxidative stress, inflammation, disruption, and then eventually disease. And so from our perspective, from a functional medicine perspective, we want to know, why did the body lose efficiency? What happened? And how can we return to optimal efficiency?
That's a phenomenal explanation. I think a lot of people out there, like, truthfully don't know what functional medicine is, as it's not still accepted as a standard, form of medicine, right? But the way you defined it, I want to summarize that because that's definitely a little different, and I like that a lot better than how I was explaining that. So we have this state that we probably were all at one point, which is optimal health, highest level of efficiency. And any deviation from that highest level of optimal health translates to, or looks like, or presents with a body who doesn't effectively cope with any issue, whether it's some sort of stress or infection of any sort, in the most efficient manner. It loses efficiency. So to summarize even that, deviation from optimal health means loss of ability to perform the most efficient action when it needs to.
Yes, exactly.
Yeah, I've never heard it defined that way. That's fascinating. And that makes a lot of sense. On the topic of functional medicine and just kind of how we look at it, how does that fit with, there's like two, because you said something earlier about just some people think of functional medicine from a general sense, just getting you back to optimal. And that makes a lot of sense from the perspective of standard Western medicine is traditionally mostly symptom-based, symptom management, because the tools that they utilize make it difficult for them to do otherwise, of course. So functional is trying to get you back to optimal. But then when we look at other diseases in the autoimmune category, for example, I've personally worked with patients where they don't have a autoimmune disease that's labeled by allopathic medicine as an identifiable disease, ICD-10 diagnosis code, like it's a recognizable disease. And so I know from working with you and consulting with you that there's a ton of other conditions that exist that just haven't got to that point. So we have almost, and I've always described it this way, sort of two categories, just getting you back to optimal, and you might be in the bucket of recognizable diseases, hasn't progressed to that point, let's get you better. But then we also have this other unknown category where this is the person that we know something's wrong. It's all over their face. They feel like crap, they look like crap, they don't even look alive, yet they go to their doctor and the doctor says, everything's fine. It's all in your head. And so that is so much more than just getting you back to optimal. That's your only solution because your Western medicine is out of options. It doesn't have an option for you when you have this particular condition. And I've always accounted this to the fact that they haven't gotten enough people reporting this particular category of symptoms to make a drug for it, to make a surgery for it. So it's still in the unknown. If we get enough of those cases, there certainly probably will be some research into a drug for it. But until we get there, there's no solution from allopathic and Western medicine. Is that kind of how you look at it too as well?
Yeah, absolutely. And I think that's a really good summation. There's this thing called a health continuum, and it's a scale from, on one side, it's 100% health. And on the far side, it's disease or death. And as you have this accumulation of factors, immune disruptions or toxic factors, anything that can move you away from efficiency, these things accumulate. And we refer to that accumulation as allostatic load. It's like the total burden on your body in whatever arena. So as you accumulate these issues, you start sliding down this scale. And there's this interesting phenomenon that occurs. In the middle of that scale is this neutral zone. And if you're moving away from really optimal health and you hit that neutral zone, you're not really seeing massive symptoms yet. However, deviations from normal labs start to appear. And in that space, and that's where those functional ranges are, it's okay, this is an optimal range. If you're in this neutral zone, those things are not in the optimal range. What's interesting in there is when people cross that threshold to the other side of the neutral zone, that's when symptoms really start to appear. But before that, you usually see one of three things. This is what we'll hear people say, because they'll run their labs and they're like, because we have a lot of people, unfortunately, that they're saying, I'm healthy and I want to stay healthy. Okay, and we run their labs, like, you've slid down this health continuum. And in that neutral zone, the three top symptoms are, they'll say, I need more sleep, I'm tired, I feel stressed, or maybe I'm just getting older. And it's, hold on, those things don't really cause an ongoing problem. And so when you look in the labs, that's where you see that picture. And the unfortunate thing is until they cross the other side of that neutral zone into poor health state, there's no diagnosis for those people. And there's clearly a divide from where they're at and what optimal health actually looks like.
That makes a lot of sense. And it's unfortunate. And we could literally do separate podcasts just about functional medicine. And maybe we should, because I definitely want to get to weight loss. But yeah, no, it's a damn shame for people that are in that window where they feel the effects of what they have, which is somewhere in that middle zone that you talked about, want to do something about it, but now they have to pay out of pocket because insurance doesn't cover anything in that realm. And it's not so much that insurance doesn't cover preventative care, although that is part of it, but anything that doesn't have, again, a recognizable traditional allopathic approach, which is more pharmacological or surgical based. When anyways, so yeah, lots of things going through my mind as far as future episodes with you for sure. But weight loss. So I'm super excited to pick your brain on so many topics actually on weight loss as I was preparing ideas. We certainly aren't going to be able to go through everything. So I think we should start, because I get asked this so often. Let's talk about the plateau. So let me summarize for you what my understanding of the plateau is, and please expand, add, or course correct. I take no offense at all. So when we think about a weight loss plateau in the simple sense, it's this effort towards weight loss that now is producing less weight loss or no weight loss, right? That effort we can define as the calorie restriction that's created from usually increase in exercise and decrease in consumption of food. And the body has many systems for checks and balances and regulations. And one of them in this category is specifically the hypothalamus, this regulatory part in your brain, detects not even calorie loads as much as it is trends, your caloric surplus or caloric deficit. So we know we got to be in a caloric deficit to lose weight and a caloric surplus to gain weight, right? Deficit to lose, surplus to gain. But your body has the center that'll detect a trend. And it makes a ton of sense, evolutionary speaking, because the only reason you wouldn't be eating, or you would be in a caloric deficit back in the day for millions of years, is because you didn't have food. You didn't have food. This is bad. And I always tell people, everybody alive today is the result of 3 million years of that. But so we literally evolved these mechanisms which kept our ancestors alive, which is an ability to respond to this trend in caloric intake, which is decreased, and then literally slow down your metabolism. So I always refer to that as a metabolic downregulation. And I guess that's getting closer to my first question here for you. When we unravel that, the symptoms that we see in patients all the time are the same as low thyroid symptoms. Not all of them, but a lot of the same. Like the big ones is decrease in energy, increase in brain fog. They're pooping less often. Those are the big three. So I wanted to pick your brain, first of all, and just the explanation of why that's happening, if you have anything to add to that. And then if you want to talk a little bit about that effect on thyroid specifically.
Yeah, no, I think that's a great summary. A few years ago, a good friend of mine, he was in the 300s, and as far as his weight, and he wanted to lose weight. And this guy's a musician, very low like income, he hadn't made it big. So he just decided he was going to start jogging. And when he started jogging, he just started shredding down, like unbelievable. And it inspired people around him. I want to lose 10 pounds, I'm going to jog. He got to a certain point and he was no longer losing the weight. And so I think the plateau is an accumulation of 4 major issues. The first is what you're saying. There's a caloric restriction, right? And so the nutrition coming in is not there. And evolutionarily, or when you're looking at groups of people that had to survive a famine, the people who survived were the people whose body could decrease the energy expenditure. So that makes sense. And what is, you'll see a change in the T3 thyroid, the total thyroid T3 and reverse T3. And what typically happens, the worse a person's nutritional deficiencies are, and this isn't just calories, it's also going to be micronutrients. And that's part of the problem that people have to be really careful with, is as they're doing food restriction, they still need to get their micronutrients, all those essential nutrients. And so calories plus micronutrient deficiencies, when those drop too low, what happens is you'll see the ratio of total T3 to reverse T3 start to shift. And a really optimal ratio there is 10-1. You want 10 times more T3 than reverse T3, but you'll see that. So you see that shift. And that's actually, there's been some theory around Hashimoto's that The reason you see it high in certain populations, there was some ancestry that survived a massive famine, and inadvertent protective effect was damage the thyroid, slow down metabolism, and those people are going to survive on less. They didn't feel great, but they survived. So from a thyroid perspective, you definitely see that pituitary downregulation, and it's a protective mechanism. So one of the things that people can do to minimize the impact of that is to make sure they're getting their micronutrients from really nutrient dense foods. And that's the interesting thing, is most nutrient dense foods aren't super energy dense. And then supplementing your micronutrients is probably incredibly important here.
I wanted to interrupt the show to tell you guys about the free resources that I have for you to be successful. The link in the show notes is going to provide you a way to join the free Facebook community. We do weekly live training. It's a great community. We'll answer all your questions with or without the medications. We're going to help you get there. And there's a free PDF which breaks down the steps so that you know exactly what to do, how to do it to be absolutely successful this year for your weight loss goals. Now back to the show. Do you think that do you think it ultimately, the fasting, or I guess we haven't even got to that part. So fasting versus calorie restriction, we can talk about that, and we should, but we'll just call it both calorie restriction for right now. So the severe calorie restriction, do you think that is simply causing the micronutrient deficiency, or do you think they're both independent drivers of that downregulation? And it just happens to be that when you fast and calorie restrict, you're probably going to also cause even more micronutrient deficiency. Or are they separate or together?
I think they're together, both caloric restriction and fasting, because I have to go back to the person I know that has measured this the most is Peter Attia. When he noticed that if he did really extended fasting, he had a real drop in his total T3 production. And I think that's a transient decrease. The body can respond, and especially if people have decent metabolic flexibility, but the micronutrients, I think, is the bigger problem. And if they're doing caloric restriction or fasting, and in their refeeding windows, or when they do eat, and even if they're doing like an OMAD diet, 1 meal a day, if they're not getting really healthy food, I think that's where a lot of people mess up. They get a chance to eat, and they're like, I can eat. I had a buddy one time, Gene from Florida. He said, when we first started talking about fasting and intermittent fasting, so you're saying I could eat chocolate cake 1 meal a day and I'd still lose weight? I'm like, yeah, absolutely, you would. It's not going to be good for you in the long run. But yeah, so I think that's one key piece. And out of the four, and I really thought about this when you'd asked, so I think one is a downregulation due to total caloric intake and micronutrients. Two is, like my buddy, when he started running, it took a lot more energy to move that amount of mass. And you decrease the mass, then it doesn't require as much energy to move that body or that physical object anymore. So your energy expenditure drops as your total mass drops. So when people lose weight, it doesn't, your body, even with the fasting and caloric restriction, the body's constantly trying to find efficiency. Energy efficiency is the goal. There was a study a few years ago on women who were marathon runners, and women who ran 80% of their max for, I think it was like 4 to 5 times a week. And that's a really fast run. I don't know how someone would keep that up, but they started getting hypothyroidism. Their thyroid started downregulating. And that's why you see runners, they run all the time and they still have that layer of fat they just can't burn. And their body has found a state of equilibrium. But the big thing is to minimize energy burn and maximize efficiency. The other thing is a lot of times you typically will see your biggest metabolizer of energy is your muscle mass. And with weight loss, if people aren't doing things to maintain lean muscle mass, they're going to burn their muscle up and then they lose that. And then the fourth thing, as you lose fat, your leptin drops. And leptin there's some preliminary research that, leptin, as it drops, it's driving hunger, which affects behavior, but it also seems to have an effect, and we've seen this in fertility, it has an effect on reproductive hormones and metabolism. And that's another mechanism of downregulation. Yeah, there was a study where they took obese individuals that were losing weight, and they saw some metabolic adaptations to lower calories, and they saw increased hunger, and they gave them injections of leptin, and their hunger went away, and their metabolic adaptations reversed. So they were able to keep losing weight and not have the hunger and not have the resistance or the decrease in metabolic rate that you typically see with a drop in leptin. So I think those are your four big key players.
Wow. Wow. Leptin is definitely interesting because in the weight loss space, it's the one that no one talks about a lot. And I have found it to be something that we don't need to talk about that often. And it seems to go part and parcel with insulin. If you're insulin resistant, you're leptin resistant. And if we improve insulin sensitivity, we notice that the leptin's not an issue, right? So I'm assuming, because we're not testing leptin, we're assuming that the leptin sensitivity is improving too as well. Do you find that leptin tends to move in sync with insulin?
Yeah, it seems. And you'll, because the one big impact that improves both is exercise. And so if people are exercising, leptin improves, and then it's easier for them to reach a point of satiety. And when I think that's probably one of the best measures, because I've only looked at leptin when we had people that had just real problems restricting their caloric intake. They're just like, I'm ravishingly hungry. And I'd messaged you not too long ago because we've been seeing this with antidepressants. And it's a known thing that antidepressants cause leptin resistance. And I have a young niece, and they had put her on a medication, an antidepressant or an SSRI, and her leptin was off the charts. It was crazy, massive leptin resistance. She's like, Uncle Dan, I'm always hungry. I don't know why. And it's interesting. Leptin is that and adiponectin are just such fascinating hormones.
Yeah, no, I think a hormonal based podcast episode, it sounds, is in the pipeline. Going back to muscle mass, yes, I'm full agreement with you how important muscle mass is for long-term sustainable weight loss. Can you say that adding muscle mass makes a person more insulin sensitive, or does it require some improved insulin sensitivity to build the muscle? Because I know they're correlated, right? But yeah, you have more muscle mass, it's more storage of glucose. And I tell patients, like, one of the tricks you can do is time your cheat meals on a day that you lift weights, because when you perform heavy resistance training, like actual resistance training, like you're trying to build, whether you're trying to build or not, you have these, besides just the muscle's ability and desire to absorb the glucose via insulin, you have also insulin independent channels called GLUT4 receptors. And so those are active. And so I always tell my patients, like, literal way to get away with more damage control on your cheat meals, just have them on days when you lift weights. And so I've been finding myself wondering, so which one came first with regards to muscle mass and insulin sensitivity?
Yeah, I think there's one other thing to throw in there is that IGF-1, because that's an insulin dependent growth hormone factor that stimulates tissue. And it's hard to say. I know that someone's free fat mass versus fat mass ratio is so important. So the more body fat they have versus muscle and bone density that's an important ratio there. And we know, just like you're saying, moving the muscle. I think it's one thing to say, okay, it's probably more important to move the muscle than have a bunch of it. But the more that you have of it, there's a typical improvement in insulin sensitivity overall, because if you have more muscle mass, the simple act of movement is using more energy because you have more mass to move.
Yep. Okay. So you can get really deep on that one, huh?
Yeah, I think that could be a way bigger discussion than we intended it to be.
Okay, so taking a step back, it's interesting. We look at the plateau. And so in summary, it's a combination of caloric restriction and micronutrient deficiency. So for people listening that are struggling right now with regards to micronutrient, I'm assuming it's not a couple specific things, or is it a generalized statement that any combination of micronutrient deficiencies, do certain ones stand out to you that tend to be the more common ones that'll lead to a plateau?
I'd say that from what we've seen, a decrease in the serum levels of amino acids, that seems to be a real problem. The body becomes super restrictive. And then the moment you don't have a good in refeeding window, or however you're going about this, fasting or like caloric restriction, I think when those aminos aren't there, your body's going to want to break down some of that muscle mass to feed you. So you want to have that protection. The nice thing is burning fat creates the ketones. And one of the things we know about beta hydroxybutyrate is it actually has a protective effect on lean muscle mass. To some degree, you're going to protect that muscle mass and not hit that downregulation so much. But as far as the micronutrients, I'd say it's just some of your basics. You don't want to become too deficient in any one area. And that's why I think testing is important. You go, okay, these are my micronutrient deficiencies. I'm going to support that. And then when I get into this fasting, I can hit it. But my gosh, it's hard to say, because someone asked me one time, what's a vitamin D deficiency feel like? I don't know. I have to test for that stuff to know. And there's so many essential nutrients. So I think overall is just making sure that you're trying to get a good variety of nutrients by diversity and your plant fibers and your natural foods, and make sure you're getting your protein and your fatty acids. I think in general, if you have a good meal, your diverse diet, you're probably going to offset that. Otherwise, the only way I know to do is testing. Some of the aminos seem to really hit people. Those are massive inhibitors when they're not available of people's metabolism. But I think that's a good area for research, because that kind of gets foggy, and I don't think it's easy to just say, okay, it's this and this that we've seen across the board. It's just in general.
So aminos is a big one, actually, because it is the lack of consumption of amino acids what triggers cellular autophagy. But then in your professional experience with the years you've been doing this, you're also noticing that out of everything, they're all important. The aminos was the first thing you said. So that stands out to you as too much deficiency in aminos is probably a bigger contributor. Obviously, generally speaking, there's other ones, but too much of a lack of aminos will cause that metabolic downregulation. But then we need it for cellular autophagy. How do you make sense without getting too deep of a balance between both so you can still get cellular autophagy?
Yeah, I think, and that's a huge question. I think one, that is very individual specific, and it's figuring that out. And there's ways that people can use to measure their lean muscle mass and bone density while they're fasting. Especially if they're doing it cyclically. And that's how autophagy was. Our ancestors, if we hunted a buffalo, we ate that entire buffalo. And then we're in this massive caloric overload, and we're lethargic, and we're digesting for days. And then then you go into a deficiency. But that's what's really interesting. When you look at longevity studies, there's populations in South America, I think in Peru, they suffer from a form of like dwarfism, and they have very low growth hormone. And so they stay in a state closer to autophagy. Their AMPK is higher, mTOR is lower, and they live crazy long. But on the other side, when you're looking at standard populations, people who have low protein intake, it has worse outcomes with lifespan as you get older. It definitely has an impact. Because once you lose muscle mass after 55 to 60, it's so hard to get it back, and that has massive metabolic ramifications. So I think it's a fine balance. Yeah, and so you definitely want to go through that restriction. And one thing I will add to that, as far as if there's any one thing that we see, I think the next piece to that, and possibly there's an argument made that it's the most important, is the minerals. You lose your minerals and your electrolytes, like nothing works right.
Oh my gosh. Yeah. So that's the most common thing with the program that we do, with the amount of fasting we do on our patients. That's very common. In addition to their electrolytes, they're also instructed for every 24-hour fast to consume an additional quarter teaspoon of sodium, Himalayan or Celtic, just because those supplement products, those electrolytes they're not intended for fasting. They're more intended to complement your diet. We get those calls occasionally. People forget that quarter teaspoon. What a difference. Oh my gosh. Within 20 minutes of I'll tell them to put the salt right there on their buccal mucosa right there in between the teeth and gum. And 20 minutes, they're like, oh my God, my headache's gone. My energy's up. And yeah, you're definitely right about that, how important the electrolytes are. And yeah, fasting, obviously you lose those. Fasting compared to caloric restriction. So when I look at fasting, and I want to get your take on it in here in a second, but so my take on it is fasting is a form of caloric restriction. And there's a lot more data on caloric restriction than fasting, but fasting is a form of caloric restriction and happens to be the most extreme form of caloric restriction over a given period of time because it's zero, right? There's no more extreme than that. And so there's so much crossover between fasting and caloric restriction, but I differ fasting, almost trying to make it sound so basic if I can, but it's the controlled form of caloric restriction. It's the most extreme form of caloric restriction that's controlled over a certain amount of days, and then you feast afterwards. And it goes back to what you said earlier about our ancestors. And that's why I titled the book that I just wrote, Fast, Feast, and Flourish, because I think for millions of years, like we were saying, our ancestors, they didn't know when the next hunt was going to be. And not eating all that food is like leaving money on the table and not putting it in the bank. And you put your money in the bank, you don't throw it away. You don't throw away food because that's a precious commodity and you want to store it in your bank, and your bank is body fat, and your body has the ability, developed it over time, to tap into that energy, those reserves whenever it sees fit. And fortunately now we've lost that ability, most of us. And that's why most of us feel so freaking crappy. Not everybody, but a lot of us feel so crappy when they start fasting for the first time. So do you have anything to add or complement that kind of differentiation between caloric restriction and fasting?
No, I do. And I definitely think that it's the most extreme version, but it also has a real potential. And I think our perspective in our clinic dealing with illnesses and disease cases, and it's each one of those has their benefit. If I have somebody who has massive insulin resistance and type 2, type 1 diabetes, especially type 2 diabetes, sometimes those people, their hypoglycemia is so severe they can't operate. And caloric restriction would be better in a mode like that. On the other hand, when I have somebody who has really severe PCOS, and there's study, Dr. Walter Longo, and he does the fast mimicking diet, but there's studies on fasting. It has, when you fast, everything breaks down. Your body's going to that autophagy, but everything shrinks, like your nerve cells, like your heart tissue, all these different tissues. And I could be wrong on exactly all of them, but they see a breakdown in all these tissues. And then the refeeding has this effect on stem cell release. The body starts regenerating these tissues. And in his studies, they found doing this over a 3-month period, this planned fasting, they were able to actually reverse certain autoimmune conditions like MS. I don't want people to go out there and just start trying it, but I think from a therapeutic aspect, they're both important. But I definitely think that fasting, like true fasting, that restriction, as far as how it drives autophagy, I don't think you can touch that in just caloric restriction.
Yep. So, okay. So definitely you're saying that they are very similar, but fasting in essence has a more powerful effect. And that's why it's harder traditionally and standardly. Yeah, no, I think that makes a lot of sense. Yeah, it's interesting. Did you see, we'll go back to aminos and fiber here in a second, but being where I come from, the hormonal basis of obesity, the power of optimizing insulin, there's so much, obviously obesity code from Dr. Fung, there's so many coaches, doctors, people out there that have really just dived headfirst into that. He said, Jason Fung set the path for everybody and gave us enough validation, not the highest level research because we don't have it, but I think what he did to make up for the lack of the highest RCTs, randomized control studies, is that's why he has 50 citations. And a lot of them are mechanistic studies, but there's so many of them that when you read that book, he's telling you a story. He's telling you a story from every possible angle. And so that's powerful. And that's what allowed me to, I was already doing the fasting, seeing the benefits with patients, and then reading that book, that's why everything's working. That's why weight loss is so much easier. My patients are maintaining their weight loss. They're getting good results. But now as I continue, because I always try my best to continue to learn and expand and be willing to be wrong. Because in healthcare and anything in life, if you're not willing to be wrong, then you're done. I've been looking a lot at these studies where, higher level studies actually, because we have more. And when calories are accounted for, the differing insulin levels did not produce any more fat loss. And it's a lot, right? Because basically you go to TikTok and you'll see at any moment 10 coaches trying to sell the Feel Great system and tell you that's the answer to everything and just start intermittent fasting and take their product and say calories don't matter, calories don't matter, calories don't matter. Yet the highest level research that we have today says that it didn't, as long as calories were accounted for, you can have the lowest carb diet, whatever you want, lower insulin levels did not produce more fat loss. So when I started seeing that, it was a big kind of almost like a punch to the gut, because I'm like, okay, now this is very contradictory to my whole outlook and my whole view. And so really taking time to try to understand that, here's where I stand on this. How could that be true? Because it is based off of that tunnel viewpoint of what that study tells us. So I'm looking at, okay, I've done both, not only for myself, but with patients, the insulin controlled, which is a lot of fasting, low carb cycling, resistance training versus just all about calories. And in this situation, the patients don't have to count calories and they get results. So how can that be? Because we just said this study shows us that it's all about calories. And so my opinion is the benefit of insulin may not produce any more additional fat loss in that controlled calorie environment, but the benefit of doing the calorie restriction in a format that optimizes insulin is going to do so much more in terms of making it easier for you to get into the caloric deficit and maintain that caloric deficit via the metabolic reaction, the hunger changes, all of these things. Because at the end of the day, who cares if we're talking about a controlled experiment of reduced calories? It's all about the people's ability to get into that. In reality, when it's not a controlled environment, can they get into a caloric deficit and can they maintain it? So I love your opinion on that. And then I also think the plateau too itself that we talked about earlier can be prevented potentially when we optimize hormones. So we'll talk about that in a second, but just getting back to my trying to make sense of it. What's your thought on that?
Let me just get some clarity because I'm not familiar with this study. So they're saying that regardless of total calories consumed, people are able to achieve weight loss?
No. So what they're saying is calories are controlled, same amount of calories, but the two arms, you had one arm where they focused on lowering insulin levels. So they were fasting, they were cycling. So lower insulin levels versus basically intermittent fasting, same calories each scenario, but this one had a higher carb diet. So insulin levels were higher. And despite what everybody on TikTok is saying, insulin, you cannot burn fat when insulin's elevated. The highest level tells us the complete opposite.
No, we know that just we see cases in the office and where we'll start somebody on a program and you can have insulin resistance due to elevated iron, right? Like high ferritin, high iron, and people will have insulin resistance just from that. And you'll still see those people lose weight, right? So the body's going to get rid of energy. So think about this, if you do have high insulin, the only way that insulin is effective is if those insulin receptors work. You can have insulin resistance and you start losing weight. Your body's going to get the energy somehow. I think there's a lot of benefit there. One of the things that you typically see in fasting, and there was a really good study on this, when you take people and you start them on a fast, and this is where I think fasting has to be controlled. And I think when people do intermittent fasting, it definitely needs to be controlled, because what they found was in the first deeper hours of being into a fast, your body still needs energy. And the highest glucose consuming tissue is the brain. And there's this mechanism occur that you'll see a massive increase of insulin resistance at the muscle and in the liver. But what that's doing is it's glucose sparing for this glucose for the brain. And so in that scenario right there, we already see an increase in insulin resistance while weight loss is occurring. Because there's other ways. When you break down your fats, you can get fatty acids in that pathway. So you're not going to always break down a triglyceride into glucose. You have fatty acid beta oxidation pathways that kick in. And that's insulin. That's not shut down by massive insulin. That's actually shut down by high amounts of glucose, although insulin does have a role in that. I don't know. That's hard to say. I'd have to see what the biochemical pathways are that you see with that. That's interesting because we do know insulin is one of the mechanisms that is the on-off switch of whether someone's going to go into a ketogenic state and use their fatty acids. But I'm sure there's other ways to get those substrates. I don't know, man. That's
because with what you're saying there's a difference between losing weight and losing a higher percentage of fat mass in that scenario versus other weight. And so I happen to believe that the presence of elevated insulin does make that weight loss, even if the calories are controlled, so the weight loss is the same. I think the lower insulin means there's going to be more fat loss, but we're trying to make sense of this right now. It's crazy.
Yeah, I'd be worried about, what the outcomes were on bone density and muscle density. Was how high was the weight loss? And did they identify, I mean, the body's amazing, it adapts, and it's like you said, it's one of those things where we have to be willing to be wrong. It's, if you ever read the Dunning-Kruger effect, it's like the more you know, the more you realize you don't know. And, the more we get into this realm, you still go, wow, there's so many things still yet to be understood about, this body that we live in our entire life. And we may go our entire life and have massive amounts of gaps in understanding how it works.
No, it's crazy. I couldn't agree more. Okay, so that's definitely, we could read that study, do another episode on that later. Fasting and aminos, right? So this is, it blows my mind that I don't see more information about this, more people talking about this, what to do with it, what to make sense of it. Just a shift in our understanding of branched chain amino acids, and we thought they were the holy grail and the answer to everything. I'm curious where your take is on branched chains. I still think they're amazing. We just understand now that they're a lot more insulinogenic than what we thought before. Like they're producing a lot of insulin, and that's not what you want when you're fasting. So what's like your perspective now on lately with the new understanding of branched chains, and that can segue into essential amino acids?
Quick minute here. I wanted to tell you guys about the free resources that I have. There's a link in the show notes. It's going to give you a way to join the free Facebook community where we'll do weekly live coaching all about the weight loss medications, on them, without them, whatever it is. We're going to help you hit your goals. And there's a free PDF too as well, which breaks down the step-by-step so that you know exactly what to do and when to do it. See you back in the show.
Yeah, on branched chain, it's pretty clear that they can stop the fast cycle. And you can see that. You can monitor that in blood. You can use it knocks you out of ketosis. There's some real mechanisms there that we know there. As far as the essentials, I think one of the things that we have to concern ourselves with is, and one of the reasons I think people hit the plateau is it is a metabolic downregulation, because those amino acids, when you take in protein and your body reforms those amino acids, those aren't just for muscle. Those are hormones. Your hormones are made out of proteins, peptides, and cholesterol. And your peptides and your proteins are amino based. So those hormones are going to go out the door. And that's a problem, because that's going to be like thyroid hormone. It's going to be like growth hormone. And that's going to impact your weight loss, because those are your fat burning, energy burning hormones. One is you're losing these hormone precursors that you need for those. The second is protein is a massive part of your immune system, your albumin, your globulin. You have to have those things. So antibodies. So and I'm sure there's some study, I'm totally speaking on what we've seen in the clinic, but when people's white blood cells start dropping and their hormones start dropping and their globulins and their albumin starts dropping and their total available protein starts dropping, I was like, why am I seeing this crazy increase in thyroid binding globulin in people when they were in a calorie restriction? In Nature, I found an article, not kidding. And I found a study that this mechanism actually happens in hibernating bears. When they're hibernating and they go into a caloric restriction, their body increases thyroid binding globulin, binds up thyroid hormone, shuts down metabolism, and preserves as much body mass as possible to maintain a long-term hibernation state. So I assume That's a very similar mechanism that's happening in people when they do start eating again, that they're not getting proper availability of proteins and amino acids to support their immune system, support their growth hormone, their thyroid hormone, and maintain what's needed. And I think that's where the balance comes in.
That makes a ton of sense. So consumption of branch chains, do you ever recommend that in your practice? Besides someone wanting to increase muscle building?
I usually tell people to focus on their essential aminos and make sure if they're doing, because a lot of people want to do a plant-based protein powder and or aminos and they're not getting enough leucine in the plant-based. I don't overly concentrate on leucine, but even with creatine is what methionine, arginine, and I think glycine. So you have to preserve muscle mass, you need the creatine as well. So those essential aminos I think are super important. And so I usually recommend, hey, if you're not getting a good protein source and we're seeing a drop in your lean muscle mass, we use the Staiku machine that does it's an infrared DEXA scan. If we're seeing a decrease in lean muscle mass, that's when we start really focusing on their essential aminos and their protein intake.
So the amino acids are so crucial for so many things. We're using branch chains less often. And I've been looking for a study. I haven't seen it, but I would love to see a 24, 36-hour fast comparing doing it while taking essential amino acids. So your calorie intake is still 0, but you're still getting 20 grams of essential, amino acids throughout the day in that 24, 36 compared to versus not. And obviously, I think we know cellular autophagy is going to be higher, right, in the non-EAA. But what are the pitfalls of not taking them? And it sounds like it could be problematic in either scenario, depending on the person.
Yeah, and I think this is where defining from the get-go what your therapeutic goal is. If you're dealing with a neurodegenerative process, or you're doing it to have a little bit of longevity, do a cycle without aminos. Do it just purely water or black coffee or whatever and make sure you're getting your minerals. If you want to do it more frequently, protect your lean muscle mass and still feel good and still be able to, especially if you want to maintain a certain level of activity, I'd say bring in the essential aminos and make sure you're getting those.
That's so awesome. I'll admit with our patients, we do it definitely because we're doing it frequently every week, and this has been one of the changes that I'm like, I've done it on a few patients, but our protocol usually is without it. But because I've been trying to look for more literature, no one's studying this stuff. But yeah, I think I might make that more prevalent when we're working with our patients as far as essentials, because I do think that could be some of the roadblocks that some of them are maybe running into, not having enough of the amino acids during the fast for sure. Okay, so fiber. I'm looking at the clock right now. So fiber, you consume fiber during your fast. Same concept, aminos, although we are talking about something that has calories now, but it's to understand fiber, we got to go real quick back to aminos. Is it calories that knocks you out of cellular autophagy, or is it aminos that knock you out of cellular autophagy, or is it a little bit of both?
Calories will drive it too, because they do have an impact on AMPK, insulin. It depends on what the insulin response is. But yeah, so you're not going to be in an anabolic, catabolic state at the same time. So it depends on the total amount of calories. But I know for sure, just like you, the research definitely indicates that certain, especially those branch chain aminos, they have been shown to drive up mTOR. And as soon as you get that mTOR response, you're immediately out of autophagy. So I know for sure that protein and certain aminos can stop autophagy, but the caloric intake, I think, depends on the insulin response at that point. I have to read that other research article you're talking about.
No, I'll definitely send this. As much as we're trying to figure this out, it's for certain that the more insulinotropic whatever we're talking about is, the greater degree of the reduction of the cellular autophagy. And so then that means you should be able to have fiber. If that's all you're having, 50 calories of fiber shouldn't knock you that much out of 100 calories of fiber if it's pure fiber. And you're feeding your gut microbiome, And part of fasting is killing off everything. But if you're simultaneously feeding the good guys while killing everything at the same time, that's also another thing that I don't see enough people talking about is fiber fasting. What's your take on that? How do you complement that with regular fasting?
No, I think that's a great idea. I'm always thinking it from a clinical perspective. If I was looking at it from a therapeutic approach, someone who'd had chronic gut issues, maybe like Crohn's disease, ulcerative colitis, I'd probably skip the fiber, especially if there's like an IBS-SIBO situation. I think the fasting by itself would probably be a better go-to. But in others, especially with weight loss, because it takes a lot, I think it's one of those things where the net caloric expenditure to burn and break down the fiber is higher than what the fiber provides. And you're going to end up in a negative, and you're getting, like you said, you're getting all these short chain fatty acids, and the butyrate is so powerful for metabolism, and it has the protective function just like beta hydroxybutyrate. I found a research article that looked at beta hydroxybutyrate and butyrate itself, the short chain fatty acid, and they both had protective effects on lean muscle mass. So when I fast, I'll take the short chain fatty acid product. That's just to keep the gut bacteria healthy, the healthy ones, and keep those. And you get that better ratio of firmicutes to bacteroidetes. That improves weight loss too, and you're going to get that by really good fiber. I don't think that's a bad strategy at all. I think that's an incredible strategy to employ, and it's going to satiate people. They're going to feel full.
That's the bit. Yeah. That's the reason why I'm playing around with it. We obviously are getting pretty much out of time. I think the GLP-1 medications, that's going to be the next episode, because that's really, everybody was talking about these. And I think one of the biggest problems they solve is that ability to shut off that food chatter, which was one of the biggest roadblocks to getting into these longer format of fastings. But I do work with patients that don't want to do these GLP-1 medications, or they can't. They have contraindications, and doing it completely with supplements, fiber fasting definitely comes to the discussion more often as a tool just for satiety alone.
Yeah. And I'm sure you're going to get some activation of those GLP-1 and GIP receptors from healthy fibers, because butyrate has an impact on those things. So yeah, man, I think that's a great alternative.
Yeah. Oh, that's awesome, man. We have ended our hour today, my man. And boy, I think there's a lot more that I'd love to talk about as far as future episodes. It was a pleasure having you on the show, my man. And I look forward to having you on again. Real quick, can you share with everybody, and we'll link it to the show notes, but can you work with everybody across the nation? How can they work with you?
Yeah. Easiest way is they can just go to the website, peakvitalitydenver.com. And on there's the form they can fill out, and our new patient coordinator can get them set up to get them started on going down a journey with us. If they want to learn more, see what we're about, I have some educational webinars where they can see the things that we really specialize in. But denver.com is the easiest, simple way to get there.
Guys, this is my go-to, who I refer to my patients when the flow protocol can't get them there, when there's something that's clearly there. The most recent one, I can't wait to hear from you as far as what you guys figure out. But yeah, he's an interesting one, but this is my go-to, guys. Any functional issues, if I've obviously haven't been able to not get you there, I'm sending you there. But if you're struggling with non-weight loss issues too as well, and I know fertility is your new specialty now, that's the direction you guys are heading, but you still take everything though.
Yeah, we still look at everything: fertility, hormones, autoimmunity, gut. Those are the most common things that we see.
Fantastic. And you incorporate peptide therapy into your treatments too.
Yes, we do.
Awesome. All right. Yeah. I'm super excited. We'll link to the show notes, guys, and to the next episode, Dan.
Absolutely. Thanks for having me.